Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. My dear fellow students and my colleagues, I've been taking the session on the Megaloblastic Anemias, and this is session 2, Folate Deficiency Anemias. I am Professor Syed as a representing Janasian Medical University. And previously I've said that this is a folic acid trap cycle. What is this? You can understand if this, you can see that homocysteine needs B12 to convert into methionine. Methionine is important for DNA synthesis, nervous system, and its fat metabolism in the liver. Even dyslipidemia can occur in the liver, fatty liver, or NASH can occur. Another, it means that it is converting into this. Homocysteine itself is a prothrombotic agent. It should convert into methionine. Otherwise, the thrombotic event will take place. So it is important for every cell. It needs methionine synthetase in presence of the B12 and folate. Both are needed. So both will cause this problem, specifically speaking, because of the folate is a what is known as the folic trap cycle. It is a cycle. Here you see the methylmalonyl CoA needs B12 and methyl malonylic acid coenzyme mutase, and it is for the converting into succinyl CoA. It does not need folate, but it is an intermediate product of the citric acid cycle or Krebs citric acid cycle, and there is a formation of the porphyrin formation. It will cause heme synthesis. So it is one of the hematopoietic agent also. Specifically B12, if it is deficient, it will cause problem here, that is in the nervous tissue, specific for this. Actually, the two cycles meet with each other, as you see here. That is called the homocysteine here, another is methyl, the B12 is needed. The folic acid is going here like this. Methylfolate, and then in the intermediate products is the folate pool, folinic acid, and other products, they are needed in this pool. But here you feel the intermediate product of the folate to form the methionine. So if you will give the folic acid in B12 deficiency, the thing is that it will going to conversion into this part, folate pool DNA, but not methionine. Because of the B12, it needs B12 also. Methionine is deposited, it is deficient quantitatively. So it is a quantitative deficiency of the B12 if you will give the folic acid in B12 deficiency. So the nervous system will be involved more and more, and there are more CNS problems seen with folate if you give in B12 deficiency. This is the concept of the what is called as the folate trap. It is a cycle. It is a cycle actually. And then we have seen how the B12 is affecting in my previous session. Shillings is not actually, we are not doing the shilling. We are doing for the B12, as I will repeat it again. Now first see the folates. It is actually, what is this? Folate is the terryl glutamic acid. It is one carbon carrier molecule. It will carry at least one carbon. For example, the patidine, it is the methyl group which is attached. It is a carrier. So it will go in the paramonobenzoic acid and then polyglutamate. This compound is methylfolate. It is intermediate product. As I said already in the folic acid trap concept. One carbon units, whatever it is, in the presence of folate, it is a carrier. It will form the methionine, purines, pyrimidines, basic substrates for the synthesis of the DNA. So it needs every part of the cell, every part of the body, every part of the tissue. Folic acid is necessary for the red blood production and neural tube formation. It is one of the homeopathic agent, plus in the formation of the neural tube formation is going in the first trimester of the pregnancy. The neural tube is forming. If there is deficiency of the folic acid, the neural tube will not be formed, and there are certain atypical type of the neurological problems will be faced by the infants. So we give the folic acid in addition to the what is iron and calcium and vitamin D to the in pregnancy to avoid these neural tube defects. It is congenital defects. The sources of folic acid from everything, animal source as well as from the plant source. Look, the plant source. All fruits and all vegetables rich in folate. In moderate amount, it is present in the animal source. Like for example, in cases of the meat or the fishes and others. But the high sources are the plant kingdom, whether they are in the fruit, in the nuts or the dried beans or the whole grains and oranges, avocados, or whatever called it is, mushrooms and so on, rich in folic acid. But it is present in the liver in high amount, no doubt, but in other tissues of the animal it is moderately present, not high amount. Dietary folate and its absorption from the vegetable, and you are eating in most of the countries liver, meat, and degraded by the prolonged boiling. If you boil the meat and the liver or vegetable very prolonged, high temperature, it is degraded actually. So it should not be highly prolonged boiling. It should be moderate boiling. Steam boil is rather more preferable. Daily requirement is roughly 100 microgram. So it is needed and all is absorbed? No. 75% is absorbed and 25% will be excreted in the feces. It is needed around 50 to 75 microgram. But its half cycle is not more than a few weeks, definitely, 2 weeks, 3 weeks. But in the case of the B12, which is stored in the liver, the half-life of the vitamin B12 is 2 to 3 years. Deficiency of the vitamin B12 appear after 3 years, but deficiency of the folate will appear in 3 weeks. And absorption is largely through the jejunum, not ileum. The folate deficiency causes the same one. The folate poor diet. What are the causes? Alcoholism. The folate poor diet, it is severe poverty. You cannot buy even vegetables and cereals and pulses nowadays. And increased folate requirement in pregnancy, hemolytic anemia is needed in cases of where the blood is lost and you need hematopoiesis. Severe osteoporosis because there is turn off of the tissues from the skin, you need more folate. To increase folate requirements is another cause. Drug therapy, for example, metformin, folic acid antagonist, even the other anti-diabetics can cause the folate deficiencies, and immunosuppressive NSAIDs. These are the problem creators. Malabsorption syndromes in any part is a tropical flu, which I have discussed previously, or stateria, which can cause the loss of folate in the feces. So, folate deficiency manifestations are the megaloblastic anemia on the one hand, megaloblastic anemia, and you will find in the bone marrow, not in the blood film. And it will cause glossitis, inflammation of the tongue, it will cause stomatitis, inflammation of the buccal mucosa, it will cause the angular stomatitis, side of the lips, and so on. So, the same one in the B12 also, B2 deficiency, B6 deficiency will cause the same thing. The megaloblastic anemia is seen in cases of the folate deficiency and the B12 deficiency. A comparison has been given here with the folic acid and cobalamin. Here is food source, folic acid, almost all foods, but high in a vegetable plant kingdom. But in cobalamin only you are acquiring animal protein. It is acquiring from the animal protein, animal source. Water soluble, both are water soluble. Site of absorption of the folic acid is duodenum or jejunum. The diseases of the duodenum and the jejunum will cause malabsorption of the folate. And here is the terminal part of the ileum, a specific phenomena occurring for the absorption. The mechanism of the absorption is the deconjugation of the polyglutinate you form, and it will deconjugate at the site of the duodenum and jejunum. But here, uptake of the intrinsic factor cobalamin complex. So intrinsic factor cobalamin complex will actually, it will be degraded in the terminal ileum cells, and then the trans cobalamin will take to the liver. Now, in metabolic function, it is one carbon transfer. It is a carbon transfer which is the main function, which I have already shown you. Cobalamin's actual metabolic function is unknown, although it is needed for the DNA synthesis, it is needed for the, it is needed by every cells, which are actually turned off on daily basis, like hair and other tissues like gastric mucosa and others. Exact mechanism of action is not known. You can say like this. Exact is not known, although we know that it is needed by the to form the DNA synthesis. Main thing is DNA synthesis. So body stores is 4 to 5 months hardly, it is weeks. But here it is almost 2 to 12 years. The mean is 3 to 5 years. In the liver it is stored. So its deficiency will occur after many years. And folate deficiency occurs in months, 1 or 2 months. Dietary deficiency, very common. In this, because it is the developed country here, it is rare. But in Indo-Pakistan, cobalamin deficiency is common because people are not, the meat products are very, very costly. Number one, or two, because in the Hindus, most of them, they don't like the cobalamin from the animal source as their religious belief is concerned. So therefore, it can occur after years. I have done the research in Thalpaka with Suresh Kumar, Dr. Suresh Kumar, Professor Suresh Kumar, and we have done on many cases where only the strict vegetarians are there, and we found that 80 to 85% are cobalamin deficient because they are only taking the milk, and milk is not a very rich source. And plant kingdoms, no plant kingdoms, very, very small amount, very hardly any traces of cobalamin are there. Deficiency state megaloblastic anemia or macrocytic anemia in the blood picture in both cases, yes. Neurological manifestation is highly seen in cobalamin deficiency. It is not seen in the folic acid deficiency. Folic acid deficiency will cause neural tubular defects. Cobalamin deficiency will not cause the tubular defects, neural tubular defects in the fetus. So this is the difference. The clinical features of the megaloblastic state, both B12 and folate deficient, you will find the megaloblastic anemia in the bone marrow or macrocytic anemia in the blood picture. Both can cause fatigue, weight loss, diarrhea, loss of appetite, fever, sore tongue, jaundice, fungal hemorrhages in severe cases. Both can cause. Why hemorrhages? Because of the collection of the high amount of the homocysteine. It needs folic acid and it needs B12 to convert into methionine. So, hyperhomocysteinemia is the risk factor for the thrombotic state. It can cause the coronary disease, it can cause the stroke, it can cause the carotid blockage, it can cause the pulmonary embolism, it can cause the portal vein thrombosis, it can cause Budd-Chiari syndrome, it can cause the renal ischemia, it can cause the ischemic colitis, it can cause rather what is called as the peripheral vascular disease. So homocysteine levels are important. But it is costly investigation, we usually do not perform it. B12 deficiency specific symptoms are neurological, paresthesias, tingling sensations, dementia, and loss of memory gradually in young people, even neuropathy, peripheral neuropathy. And it is a combined degeneration of the spinal cord. Lateral columns are gone and the dorsal columns are gone by the demyelination of the spinal cord. Very specifically in cases of the what is called as the pernicious anemia, which is autoimmune disease causing the B12 deficiency. Specific for the pernicious anemia, because we are talking about the pernicious anemia, because it is the actually multifactorial disorder, it is autoimmune disease associated with the polyglandular autoimmune diseases. Family and personal history of vitiligo is there. It can cause diabetes, it may be associated with it, and autoimmune thyroid disease, that is called the Hashimoto thyroiditis, and it can cause the pernicious anemia itself. The pernicious anemia, along with vitiligo, along with the thyroiditis, along with the adenocortical insufficiency, is called the polyglandular type 1 or polyglandular type 2 autoimmune diseases. You see the CBC interpretation, the hemoglobin percentage is 10.6, which is mildly anemic. Patient is not very severely anemic. अगर वो starvation, if there is starvation and inanition, then it can cause this lowering of to hemoglobin to 5 or 6. Otherwise, it is usually mild in 80% of cases. It is mild. Hematocrit is 32%. It is not lower much. Look, this MCH or MCH, they should be normal. MCH is normal, MCHC, those are normal. So they are normochromic. MCV is high, much high. In Pakistan, it is usually about 78 to 95. If more than 95, it means that there is B12 deficiency. But in the developed country, it is written 80 to 100 because they are alcoholic population. Usually they have got MCV higher. It's more than 100, 125, it's much higher. Much higher. Macrocytic anemia, macrocytic normochromic anemia. And WBC is also dependent on this formation. You need B12, you need folic acid. So WBC, specifically B12. So it is also reduced. So it is associated with, in some cases, with the leukopenia. Also platelets are decreased, you see. It is pancytopenia, it means that. Macrocytic normochromic anemia with the evidence of mild leukopenia and mild thrombocytopenia. LFT is also disturbing in this case, also remember, because hemolysis occurs. Specifically speaking, B12 is concerned. So patient may be mildly jaundiced. Remember this also. This is an important point. If it is macrocytosis in the blood picture, it may be megaloblastic or it may be non-megaloblastic. Megaloblastic means the evidence of the megaloblasts in the bone marrow. It occurs because of the deficiency of the B12 and folate. But macrocytosis can occur other than involvement of the bone marrow, like alcohol, like liver diseases, like myelodysplasias, like we can say hypothyroidism, in reticulocytosis, and so on. Although it is not megaloblastic, but it is macrocytic. So it is the hematological reporting case of a macrocytosis. The hematologist or histopathologist will will call it megaloblastic anemia, while hematologists and clinicians will say it is macrocytic anemia, because they have not done the bone marrow, they don't know about it. The exact diagnosis in all cases, blood count, serum B12, serum folate levels, or rather erythrocyte folate levels are more specific. In selected cases, bone marrow, serum homocysteine, although costly, and methylmalonic acid. Homocysteine and methylmalonic acid are deficient in B12, while only the homocysteine levels are increased in the folate deficiency. Serum folate levels, LDH levels, they are also definitely increased, and bilirubin. It is indirect hyperbilirubinemia which is causing the mild icterus. Where pernicious anemia is suspected, then you can go for the Schilling test, absorption. Nowadays, they are not doing it. The Schilling test, there are modified Schilling tests they are doing. In the megaloblastic anemia, the therapy I already said before, to treat the primary cause. If it is B12 deficient, you have to replace it by hydroxycobalamin. You have to get to 1000 microgram of the hydroxycobalamin. At least it should be given, start with the 0 after 7th day, and weekly it should be given. And then after 15 days it will be given. Then after monthly it will be given for 5 to 6 months, and then see the levels. So in cases of the folate is concerned, you have to give the folate, tablet folic acid or folinic acid. Tablet is absorbed very, very quickly. But remember, the oral B12 is not properly absorbed. So it is given in injection form. Other than that, you can promote what is called as the diet. Diet should be mentioned to the patient. How much diet he should take, what type of diet he should take for the folate, for the B12. When levels are back, can stop the normal vitamin, and you can only do what is called diet therapy. Transfusion to be avoided unless the hemodynamic compromise is present. For the patient having angina, there is a condition which is already comorbid is there, where the transfusion are needed. Otherwise, transfusion is rarely needed in this condition. I have seen many cases of B12 deficiency. Very atypical symptom I have seen. Psychologically, and the patient have already labeled the bipolar disorder, or the patient has got what is called schizophrenic, and I have stopped it, this diagnosis, or discarded this diagnosis by labeling it B12 deficient. I replaced the B12 and the patient was fine. And all the drugs of antipsychotics, they are withdrawn afterwards. They were withdrawn previously. So care is there because actually these patients need the proper aftercare. They should take folic acid tablets if they are deficient, or vitamin B12 should be taken, and it will be stopped, and it should be replaced by the diet. But remember that in this condition, the hypokalemia in severe cases occurs, severe folic acid deficiency in severe B12 associated with hypokalemia. Potassiums. But the potassium is also absorbing, remember, from the same root. And the megaloblastic anemia response to therapy is very, very nice if you will go for this, whether you are giving the folic acid, whether you are replacing the hydroxycobalamin B12. His response is very quick. You say in 15 days, 20 days, 30 days, patient will become very, very, responsive to the therapy, and gradually it is in the normal levels, and patient is fine even after 30 days. But we will watch it for the 6 months. Summary is there: the deficiency in the folate or B12 will cause the anemias. It is macrocytic anemia by the blood picture, along with the possibility of the mild leukopenia and the mild thrombocytopenia. slowly developing anemia usually well compensated. This is very important. Otherwise, in other cases, iron deficiency or in hemolytic anemia, the anemia is actually very severe. Response to the therapy rapid is very dramatic therapy. You give and replace the vitamin, the patient will be fine. Dramatic response. Treatment is essential to avoid other complications. Treatment should not be given. The other drugs will actually antagonize the absorption. So do not give with the complexes, vitamin B complexes जो कहते हैं, or with the vitamin D complex or vitamin calcium or mineral complexes. No, separate vitamins are given. So they are should be clearly absorbed and in empty stomach. Okay, then anemia is secondary to the underlying cause process. Anemia is secondary to an underlying disease process. It may be the other cause of the anemia. If you are treating this, possibly the anemia is not cured, then it is another comorbid which is causing this problem. So you have to evaluate this patient again for the another cause of the anemia. Hypothyroidism, for example, you are replacing B12 and folate, but patient is hypothyroid. It is macrocytic anemia. It is not megaloblastic, but it is macrocytic anemia. So I have done the megaloblastic anemia in detail. Account has been given to you. This is cyanocobalamin deficiency, B12 deficiency, and folic acid deficiency. Both are covered in 2 sessions. I hope that you have understood it and you should remember it, and you should take the proper history of the patient, go for the clinical examination, go for the specific tests, avoiding the shedding test. Of course, it is a very costly modified shedding test. I hope that this lecture has benefited you. Assalamu alaikum wa rahmatullahi wa barakatuh.